Hey guys, welcome back to The Pathway. I'm Taylor Henrik. This is my co-host Sarang Patel.
Hey guys.
Today we're going to be talking about some of the controversies that are facing us in healthcare and how we're navigating some of these difficulties. Let's get to it.
Let's get it.
So what do you want to talk about today?
Controversial topics.
Okay. Controversial topics in healthcare, mental health care, or in life.
Let's do mental health care.
Okay. Okay.
My biggest controversial topic is I think that during COVID,
Mm-hmm.
there was a huge uproar and a huge spotlight on mental health treatment and the needs of it,
Yeah.
and how there was a lack of infrastructure to support mental health care.
Okay.
I would argue that we are, when did COVID end? Or decrease?
Officially, I think last May. It was May of 2024, I believe.
Oh, really? That's when it
I'm
ended?
sorry, May of 2023,
Yeah.
where all the COVID,
Medicine stuff changed.
like the pandemic designation ended.
Okay, so let's say
We can fact check that.
we're 2 years out. Let's just guesstimate 2 years out.
Mhm.
I do feel like there's now a downtrend
In
support for mental health treatment.
okay.
More stipulations on telehealth rules, more stipulations on reimbursements and how reimbursements are going down, as we found out today, for telehealth treatment for mental health. The whole idea of we still can't even, 3 years later, 5 years later, we still can't come up with what the in-person requirements are for Medicare, for DEA requirements, for control meds.
Yeah.
What are we doing?
What's changed between 2 months ago and now, where all of a sudden telehealth has to lapse? What is the shift? If it's working and we're all achieving good outcomes, whether you're hybridized, fully in person, or you're a full telehealth clinic, what has changed that has to make it go back to the way it was pre-pandemic?
Money.
Yeah, that's it.
So if you are an insurance company or if you are paying for coverage, this is my take on it, right? So take it with a grain of salt. If there are 10 appointments, if a patient's seen 10 appointments in a year, they show up to all their appointments because they can either come in person or telehealth. So the hit rate is 100% because they were accessed. They were seen, they were billed 10%, 100% done, 10 visits done. If I say, hey, you know what, you can only do telemedicine 2 times that year and the rest have to be in person, a patient is more likely to miss an appointment or reschedule due to conflicts or transportation or traffic, which clearly we have a lot of construction here, right? Clearly. They're going to maybe miss an appointment. So out of 10, I may only see that person 8 times that year.
Okay.
So as an insurance carrier, you're saying, well, I didn't pay for 2 appointments because they missed 2 appointments. I didn't pay for those. So I saved $200.
And there's your controversy.
There's
That's the point you're making. Okay.
That's the point.
Okay. I think there's validity in that. I can't really argue with it because the math adds up,
Yeah.
right? If your client is steady and stable, unfortunately, being honest, coming in person is now almost a barrier for a lot of individuals who may have either lost their jobs, lost their cars, or don't have the ability to come in the middle of a work day. Like we're seeing clients during the school and the work day. We can't all work in the evening and accommodate everyone else's 9 to 5. So you're asking that individual to leave wherever they are, right? Or come in from home, whatever that situation may look like. And now that's almost a barrier to access
Yeah. So what
in some instances.
if it has been so bad? The argument is well, okay, what if telemedicine is not actually accurate? It doesn't actually treat the patient in the best interest. It's not what we want it to be. It's not the best quality of care. So you're telling me for the last 5 years we've given crap care? So what have we done for the last 5 years?
What about before that?
Yeah.
In rural communities that were already doing telehealth almost exclusively because they were underserved. So now that's disvalidated?
But for 5 years, when the amount of mental health care I would say healthcare in general is more accessible, right? Because of telehealth, you increase the amount of medical services provided, right? Besides surgicals and stuff, but those visits, we're going to say, well, while we increase the number of visits provided, the quality was poor, so now we're going to take those restraints away.
Right.
No, it's because we increased access to care, the cost went up, so now we're going to say if I put more limitations and boundaries, the cost will come back down.
For the payers.
Yeah.
Yeah.
It's that simple.
Thus subjugating or making it more difficult for your clients to get the care they need.
Yeah.
I agree that this is probably the largest controversy facing our part of the healthcare industry. You see it in the telehealth guidelines that are coming out. And again, this is not exclusive to telehealth. Our point being that overnight, seemingly, some of these changes are happening without a clear-cut rationalization. And that's the concern I have. So you see it in the telehealth guidelines that now there's a designation, whether it's primary care or home-based visits or behavioral health. Behavioral health has its own set of rules per CMS and per .gov organizations.
Right.
Why is that?
Because out of most medical practices, I think we can get away with. We can do more telehealth visits. A lot of times they're checkups. A lot of times they're a lot of talking, kind of working through some things, right? So prescribing medication, whatever it is, less procedural based, less physical based. They can be.
In some instances, vitals aren't quite as important, right? Laying hands on the patient is not something we do in terms of a physical exam, right? So it allows itself, or it's an environment where telehealth makes sense. It's reasonable, right? And there's been some adaptation and some early adapters, but then there's been some resistance, right?
And it should be the patient's choice. If a patient is saying, I want to come in, and I'm saying, you have to do telemedicine, that's not right.
Correct.
If a patient's saying, I want to come in, and you're saying, well, we only have telemedicine available, we don't have in person, the patient can go choose a place that can do a hybrid model, both in person telehealth or just in person, right?
Absolutely.
But now it's not even the patient deciding it. It's not the clinician deciding it. It's the insurance company deciding it.
Right. It's not a decision being based on medical necessity.
Yeah.
It's being based on money and the bottom line, unfortunately. And that dictation is leading to, it's coming to a head where there's going to be another culmination of this, and it's going to lead to people falling off of services. You're going to have another epidemic or endemic issue with mental health decline. It's great that it's in the news. It's great that there's pioneers and individuals who are willing to talk about it. But is that enough? It's not going to sway a health insurance to make a monumental change or stick with what's been the MO now for 5+ years.
Yeah. Sometimes you don't expect the health insurance company necessarily to rule in the favor, I think, of patients. I think we've all never heard of one person being like, yeah, they're in my favor. I haven't heard of that ever. But I'm surprised that CMS guidelines are not really pro telemedicine or pro, really, let's continue to make sure they get access to care. It's the patient's choice if they want to come in or not come in. If you can sign out AMA from the hospital, right? If you choose to,
right?
If you have right mind, sound mind, and capacity, you can sign out AMA. Then how come you can't choose how you get your care?
Right.
I can choose to say when I don't want my care, even though I probably should have my own care at the time in the hospital, right? How can you choose then to not be able to decide how you receive your care, whether it's telemedicine or in person?
Right. Based on your level of comfort and what's going to work best for you in your unique situation. If you're a working individual or otherwise, if you're at home, say you have transportation issues, say you have a disability that disallows you to go in, you have to now rely on somebody else to get you there. There's so many different scenarios. Play them out over and over again, and now you have a barrier to care. You have someone who's unable to complete the appointment that's going to be able to allow them to continue with therapy, right? And get the care they need, or medications that might help them to stay in a stable space or the right mindset.
Yeah, you lose the ability to continue to maintain stability with the patient. You lose the ability to have that person not make a disability claim because short-term or long-term or whatever it is, because hopefully they can get medications or therapeutic services and get back to the workforce. They can hopefully do volunteer work. They can hopefully be a better person for their family. They can hopefully enjoy their retirement. Whatever these aspects are. Now we go back to the old days is like 6 years ago, right? When telemedicine wasn't as available and mental health wasn't as big of a conversation, I feel like. Where it's like now it's even, you may not financially see it until that person is hospitalized, right? Or they file a disability claim, whatever it may be. So it's like we miss this whole group of people that don't get to that extreme level in the severe range, but are in the mild to moderate range that just stay in this range here.
Yeah.
And they're the ones that suffer. Which then when we talk about, we do speaker programs, we talk about this stuff, right? The impact of someone suffering from mental health, just like physical health, is not just that person. It's their mom, their dad, their family, their siblings, their children, their family. All across the board, the groups suffer as well, or they feel it.
Yeah.
So it's like now you have that trickle-down effect where all the mild to moderate mental health patients who, don't get to the point of being extreme, you don't really recognize that now it affects thousands, millions of people outside of just the people that have the actual diagnosis.
Mm-hmm.
So like, why are we going backwards here?
Right.
And the argument I'd get was like insurance companies can just cut the contract with the clinic for no reason.
Right.
It doesn't make any sense. So you go through your entire career, you're saying, well, let's increase the access to care. Let's increase healthcare. Let's make sure we do a good job.
Mm-hmm.
For what if you have no control?
Correct. And how frustrating is it that a payer can just decide, hey,
Yeah.
we're going to cut ties with you. This entire population that you've been helping for years, you're no longer going to be able to serve. Talk about putting a client into a pigeonholed situation. They either have to switch to a new health insurance or a new provider altogether in our great country, or stick with that insurance company and change to a whole new provider just because, without due cause, right? It's the same idea in a clinic. Like, we don't drop clients for no reason. We would never leave a client abandoned. We always want to make sure that our clients are well taken care of and we're well-intentioned individuals. But if a client decides to seek out services elsewhere, they have every right to do so. We don't tell them, well, it's us or nobody, right?
Yeah.
And we don't cut off their services and say, you can't go see our competitor. You can't switch over to a competitor just because we don't want you to. That's not reasonable. It makes no sense.
Yeah, I don't know. I think sometimes it makes you wonder why. It makes you wonder how you tell the next generation to go into medicine.
Mm-hmm.
No, honestly, right? You a guest lecture at a college. You talk to a class about, hey,
Yeah.
you should go to PA school, NP school, MD, DO school, nursing school, whatever it is.
Mm-hmm.
You know, counseling school, whatever you want to go to. How do you look at them and say, yeah, there's a lot of stability. It's been there forever. It's always going to be there. You have control over your patients. You have control of how you see your patients. You have control over their entire medical treatment when you don't.
Mm-hmm.
When you're in school, you have no idea what's going on. You're just studying medicine.
Mm-hmm.
You don't understand the business end of it. You don't understand who decides who's paying what, how insurances work, what insurances you can even take.
But this is where our conversation is different because we are entrepreneurial. There's plenty of positions in the hospital where you are going in, punch out, and that's it.
Yeah.
And there's absolutely nothing wrong with that. You and I have both been in those positions.
Yeah,
and we
fine.
enjoyed it very much. But it is different. Hospital-based systems are well-backed. They're fully funded. Those hospitals usually aren't just closing on a whim, right? You don't usually have a payer come in and say, we're just not going to support any services at this hospital.
Right.
So it's not something that affects the larger population. In the outpatient setting, when you're advocating for yourself and you have to go through credentialing processes and you have to be aware of those types of things, it's a lot different. It is. You're hoping that things work out.
But it can still affect big systems by maybe they don't say we're going to cut your contract because you're a big hospital, fine. Mm-hmm. But follow-up appointments with telemedicine for post-surgical treatments,
100%.
for internal medicine, family medicine, OBs, all this stuff increases compliance, increases the quality of care by having telemedicine available for those patients.
Absolutely.
You can follow up easier. They miss their appointments hopefully less. Hopefully they're more compliant with their medications.
Yeah.
To reduce the burden and the overhead for less ER visits. So then to decrease the cost to the hospital and increase the insurance companies. It's cyclical, right? I think. Now I'm not saying I know all of it because I definitely don't, right? But I think that you want to continue to proactively treat medical conditions, which means having appointments, accessibility with telemedicine, versus waiting for it to spiral and then being forced to treat it when it's more expensive and cost at that point, and also worse for the patient.
Yeah.
But we're going backwards again.
We are.
Like, we're back to where we were. We're getting closer and closer to before pre-COVID, where it was like, oh, you can't come into your appointment. Sorry.
Mm-hmm. I don't have any controversial counterpoint to make because it's very frustrating. We're in a world where we render a service, so say you go to buy bananas, you know what the fixed cost of bananas are. You're getting the bananas. It's not a matter of like, I'm going to pay $1.89 and I don't know if I'm going to get a banana. For us, we render a service. We're an in-network provider, and we may or may not get paid. And that's at the behest of the insurance. It happens all the time. There's no rhyme or reason to it. You do the right thing. You do all the right processes. And it's just a hard culture. It's a hard day-to-day not knowing whether you're going to get paid. It's not even just about the money. It's just from like a provider standpoint. You do the work. You did everything right. And you still don't know, even being intentional, you don't know what that's going to look like on the other side.
Yeah, I don't know if we ever really changed that because I feel like it's always been like that, which doesn't mean it's always the right answer, which we should actually try to fix, hopefully, right? But I think that from a patient, if you look at it from our shoes from a patient standpoint, if I can't make my appointment, or if my appointment's going to make me miss work, get a point at work, or get me and my kid out of school, and I have to leave my job to get my kid out of school, to then get into the appointment, and then get home, because there's not always appointments available till 8 p.m., 9 p.m. It's rarely available, right? Or weekends. I'm just going to say, well, they're not going to get treatment.
Right.
I can't afford to do it. So it's like, how do you want everyone to go? Society's going faster, succeed, do well, but then not give them the access. I don't understand it.
I agree with you.
And I feel like if they take away the access, if the access changes completely again, then what are we doing? Like, what are we doing here?
I have a side question for you.
Yep.
Okay. What's stopping one of the big payers or a new, say like a health insurance buys out a smaller subsection and wants to grow, right? We know all the big players in the game in our state. Each state, it varies who the big payers are, but some of the bigger nationwide companies. What's stopping one of them and just saying, behavioral health services are covered? Your services are covered. You're going to be covered. You're going to be taken care of. What's stopping them from doing that? And I don't mean simplistically. Obviously, it's a money thing. But like, your services will be covered at a reasonable cost, right? Like, wouldn't everybody contract with them? Wouldn't they just go buku bucks if somebody was actually behavioral health forward? Are there any health insurances that are favorable or it's advantageous to have that health insurance that covers behavioral health services?
No one that sticks out to me here in Michigan.
Right.
And if they are, they're not doing a good job of telling people.
Right. There are behavioral health subsections of some of the big payers, but universally amongst our patients and amongst billing and credentialing teams, they aren't considered to be the best insurances.
I used to think that Michigan Medicaid, because they cover medications, right, one of 6 states, it's the carve out, it's great, it's awesome, is good for medication treatment. But after seeing how Medicaid plans can operate, how MCO plans can operate, how can you say that they're in the favor of the patient? You can't just cut contracts with clinics who have 800 people that you're seeing every year and saying, well, they'll find somewhere else to go. You find somewhere else for them to go, not me.
Right.
Like, what do you mean they'll find somewhere else to go? So when they call us, what do I say? Call Meridian? Do I say call BCC? Do I say call this MCO plan? It's not a practical thing, right? This is like lives. You're not talking about, oh, we don't have this car in our dealership, find another dealership to go to. You're talking about lives here, care here. They're on a medication, a 6-year-old, a 10-year-old, an 85-year-old. What are we doing here?
Right.
In a rural area. There's always been a protection for rural area coverage. We're also, oh yeah, they have like, less regulations. They're good because the access is there. No. Now you can truly see that if they can do this, there is literally no control.
Yeah. There's no comfort level.
Yeah, and money needs to go
stability.
around. And I get it. Money needs to go around for sure. Like, you got to pay your bills, got to do this. 100% I get it.
But when you are doing the right things, and we pride ourselves on trying to be morally, ethically, and mental health related focused, we want to do everything right by our clients. It's not about us. It's about the patients that we serve. Why else would we guarantee a psychiatric evaluation within 7 days? Why else would we take every possible step to make sure that we can see every insurance in the state of Michigan? And we still have barriers. We still can't get in network with certain insurances because they have too many behavioral health providers in certain areas. Where are they?
Yeah, never heard that before.
All we hear is that other clinics, no offense to them, they're all busy, which is great, but they have long wait lists, right? It's not their fault. It's just they try to keep up with the demands just like we do. But where are all these mental health providers that an area is so saturated with mental health providers that you won't let someone in network?
Or their backlog is 2 years. Oh, it's taking us 2 years at credentialing and 3 years. So people in that area just go without treatment for 3 years because you're behind in backlogging? Like, what are you talking about here?
It doesn't add up.
No. So the controversial thing is, I think that healthcare, although we're in it and we're doing it and we're in business with it, there are so many things that we don't control that patients, I think, see now more and more. That used to be like, oh, the clinics are making their money and the hospitals are making their money. No, it's not us. Like, we're not in the middle here making this bankrolls in the middle. We have no control either.
Right. We are starting with one hand behind our back.
Yeah.
And all we're doing is saying we're going to be patient focused. We're going to do everything we can to help our patients. And the money falls where the money falls. Because we're taking that risk. By seeing all insurances, that's a risk that we knew early on with Peer Psychiatry of Michigan we would take on. We knew. Like, we are doing something that is not the norm in outpatient practice when it becomes behavioral health. We know that there's risks associated with that. And we said the key here is accessibility. The key here is we want to help more people. We don't just want to help one subsection of individuals.
Yeah.
And that's where I hope that this controversy, this part of this discussion, hopefully opens somebody's eyes or informs them of what we're dealing with on a day-to-day basis. And we hope that you see that we're trying to do what is right by the client, what is right by our team, and what's right by our providers.